Yes.
Okay. All right. So I promised Simone that I wasn't going to answer any like specific questions about people's condition because I'm not their doctor. But if you ask me questions, I'll try to translate it into a generic question that I will try to answer, kind of like a textbook of psychiatry, or maybe like an AI might answer the question if they did. We were just talking about AIs here earlier, how an AI might answer the question. So, okay, so where does this? Okay, so I'm going to talk about medications today. This is a medication Q&A, but also open to other topics. I've collected the questions that we've received, and I'll try to touch upon the ones that we've gotten. So if we talk about medications, I tend to divide up medications into 4 major mood groups. That'd be mood stabilizers, atypical antipsychotics, antidepressants, and sedative hypnotics. So the way I like to do is, this is the overarching way psychiatrists think about it. I think this is the way you should think about medications also. Think of them in clusters, and then learn about each group first, and then you can learn about like each special medicine under that group later. I'm not going to touch on like psychostimulants because that's not like typical medications that we use. And these are more medications I'm familiar with for like bipolar disorder. But also, obviously, antipsychotics are used for other things. So I'm not going to go through all the categories. I'm going to focus on the mood stabilizers and atypical antipsychotics today because we really just have an hour, right, Simone? So we'll just shoot for that. So just in case you're interested, though, I did put, here is a slide that shows the different under each group of medications, a list of other medications that could be of the specific medications that could be considered within this group. So under mood stabilizers, we have lithium, Depakote, also known as valproate or divalproex, and Tegretol, which are the mood stabilizers. These are some what I call not really mood stabilizers, in that they don't stop manias, but they're still called mood stabilizers. Those are lamotrigine, gabapentin, oxcarbazepine, and topiramate. They haven't been really shown to work that well for people with bipolar disorder, but they still have their uses from time to time that could be helpful. These lamotrigine most helpful for like kind of helping with depression for people with bipolar disorder. Then we have, say, antidepressants, and under antidepressants, you can see there are these different categories of, and some of you of which you may be familiar with, but like SSRIs, which are selective serotonin reuptake inhibitors, SNRIs, serotonin and norepinephrine reuptake inhibitors. We have these serotonin receptor agonists, MAOIs, et cetera, et cetera. I'm not going to go through all the details. And but you can just see that each big group has little subdivisions that you can do. Okay, and we'll go through the mood stabilizers and atypical antipsychotics today. So first, let's the mood stabilizers. So these are some of the questions I got so just in case you were interested. So what's the difference between lithium carbonate and lithium orotate? What about people are afraid of long-term side effects on their organs? What are these long-term side effects and how often do they occur? I didn't put down how often they occurred. For medications with side effects, how do you talk to people about them? And how do you talk about not taking on it? Because the downside, you have to weigh like risk, pros and cons, not just focus on the potential side effects of medications, but you want to think about how likely it is that they're going to help you too, because that's the other part of the equation. And then lithium having a protective quality for the brain. We'll talk about that too. Okay, so these are the mood stabilizers. I mentioned them all really quickly already, but these are lithium, Depakote, and Tegretol, or divalproex carbamazepine. These are not really mood stabilizers. And the idea with mood stabilizers, you take them every day. And the idea for people with bipolar disorder, a lot of times mood stabilizers, you get it at the dose that you can tolerate. That's the most important thing. But sometimes you still may have breakthrough symptoms. And in that situation, then you can use antipsychotics as a backup to help nip episodes in the bud, for example. So one thing that happens to people with bipolar disorder, for example, is that once they start getting manic, it initiates this big sequence of events where they get more and more manic, and they stay really intense. It can get really intense to the point where they have psychotic symptoms like being paranoid or hearing voices or being delusional, and then they crash and fall into a depression. And typically the manias can last for several weeks to several months, and then the depression can last up to like a year afterwards. So that whole sequence of events might be nipped in the bud sometimes if you can break that mania first. And so if you have a little bit of antipsychotic that will nip it in the bud, that could be really helpful. Now, antipsychotics like Seroquel or Zyprexa, for example, can be really helpful to block manics, manic symptoms or manic episodes, but they cause a lot of side effects. And therefore, they're not as good to take every day. And we'll talk about the side effects of antipsychotics as well, but mostly they're like super, in the short term, they're just super sedating. So like who can, function sleeping 16 hours a day? So antipsychotics may not be the best long-term thing, and there are other side effects too, and mood stabilizers tend to be better tolerated in the short term. So the idea would be like you're on a mood stabilizer, and then if you have a little breakthrough symptoms, you might use antipsychotics. That's like a key principle for many, for people with bipolar disorder.
There's a great question in the chat box.
Yeah.
In regards to lithium, does the effectiveness decrease if you don't take it regularly?
You're more like, if you don't take it, it depends how not regularly you mean. Like if you miss it once a week or so, it probably still works okay. But if you let the levels get too low in your body, it begins to not have that preventative effect of mania. And then and that level is different for every person. So whenever you miss, it's a little bit of a gamble. Like I said, if you miss like once a week, it's probably not that big a deal, like a normal person. But if you start missing more than once a week, then you might begin to wonder, am I really getting the full benefit from that? So lithium is the best studied with the highest efficacy, and it does offer neuroprotection, as mentioned before. And interestingly, it also decreases suicide rates. This is the only psychiatric medication that, like in the short term, we do know that like from epidemiological studies, if you give a, like a county that gets antidepressants, like in the UK, they have these studies where they can show if this population had access to antidepressants, they're less likely to commit suicide overall. But with lithium, it's really like an obvious kind of relationship that is not mimicked by other psychiatric medications. So what evidence do we have for lithium? And this is for lithium for people with depression, not even bipolar disorder, but even lithium in the treatment of unipolar depression does seem to be helpful. And this is what's called a meta-analysis. And they take a bunch of these studies and they kind of group them together. And what they do is they put them here in these, and this shows like how benefit each one is alone. And you can see that they're not as potent, but if you pool them all together, you get a much more strong statistical signal that shows that it's helpful. Like each one of these like long bars show like there's some lack of confidence about where it is. That's the range of how helpful it could be based on the statistics of it. But if you pool them all together, you get a much stronger signal that, oh yeah, it's way helpful. Lithium has some neuroprotective qualities. So this is based mostly on like they're associative studies. We don't have like long-term studies to show this, like, because you can't put someone on placebo long-term to show that it helps them. But in petri dishes, like in like little chemical experiments, you can show that the lithium will cause, and what they're trying to show here, see this neuron looks kind of sparse and weak. If you give it lithium, it tends to it gets bigger, it grows more, and has more of these little spines on it that is what's called dendrites, and then the connections to other neurons. So if you give in petri dishes and in rats, you can show this to be true. Like rats, but to show it in rats, you have to give them the lithium, and then you have to kill them and look at their brain. So it's not so nice, but it does seem to be an effect of lithium. And in humans, you can show that like gray matter, which is like the part of the brain that contains all the nuclei of the neurons, that is improved with people on lithium. So gray matter volume, people without lithium and people with lithium, it does seem to be bigger. It seems to be better. So that, I mean, that's not a direct thing that's good for your brain, because we don't know directly that gray matter, in any individual person what that means, but in general, it is better, I would say. It's kind of like if you see someone has more muscles, that looks better. Whether it actually means that they're strong or not, you have to actually, it's not easy to test. Similar with someone's brain, whether it's actually working better, it's very hard to test. But with lithium, at least the volume is bigger, the gray matter volume. Lithium has all these, and this is another meta-analysis with like gazillion studies you can see here using the same kind of technique of meta-analysis, where they get a whole bunch of studies. Each one is relatively weak, but if you pool them all together, you get a kind of a strong signal that shows it's a significantly decreased risk of suicide if the person's on lithium. Numerous international, I'll just read this quote here of one of the studies. Numerous international studies of lithium have documented anti-suicidal effects since the 1970s, despite the unambiguous evidence of lithium's anti-suicidal effects and recommendations in national and international guidelines for its use in acute and maintenance therapy for affective disorders, mood disorders, the use of lithium is still underrepresented. So that's just a quote from one of these studies. So lithium has this formulation. It comes in different kinds. There's lithium carbonate, which is the original and the cheapest. Comes in 300 milligram capsules, also in 150s and 450s. So if you want to go for that in-between dosage, you can. I find a lot of patients are like, I'm at 900 and that seems like a little too little, but then when I take the fourth pill, 1200 milligrams, that's too much. It turns out there's a 150 milligram pill you can use. There's also a 450. So if you do the math, you can take 2 300s and 1 450. There's a lithium citrate, which is a liquid, but it's like no longer available through the pharmacy. I'm hoping one day it will come back. But that made it really easy because then you could take exactly how much you wanted it by, tapering how much, like drawing it up in a syringe. You could take just much less. So you could get down to like 50 milligram little dosage increments if you wanted to. Lithobid is lithium carbonate that's packed tightly in wax and other components to make it dissolve more slowly. So that's what they call by lithobid or lithium CR formulation. So they have escalith, same thing. But if they have escalith CR, it's a slow release version. The advantage of a slow release version is it comes out in your body more slowly. When you take the pill, it kind of goes into your digestive tract. And it takes a while before it dissolves. So it's a more gradual onset. It's not necessarily better for you, but if you have stomach problems with lithium, sometimes having a slow dissolve can be beneficial. Similarly, with the slow dissolve, you have diarrhea. That's at the other end. If you take the immediate release, it may help with the diarrhea at the other end because it's dissolving sooner. It doesn't go all the way down to the back end, as it were. And these are just models of lithium carbonate in little forms. Now, so there was a question about what is lithium orotate? There's a compound called lithium orotate that's basically elemental lithium. It's the same. If you take it, it will dissolve and release lithium. But by the way, just if you remember general chemistry from the stoichiometry of it, lithium orotate on a milligram per milligram basis doesn't contain as much lithium. So if you take 100 milligrams of lithium orotate, you only get 3.8 milligrams of lithium ion. Whereas if you take lithium carbonate, you get 18.8 milligrams. So I was reading on Amazon, some people who just like switched over to lithium orotate, because you can buy lithium orotate on Amazon, and they were saying they felt so much better. They had no toxicity. They were getting really happy, and I was really worried about a long screed about how great it was. I was worried maybe they were starting to get manic or hypomanic. I didn't feel morally like I could reach out to that person and say, hey, you think you're getting manic? That's not something one does on social media on an Amazon thing. But just so you know, it's not going to give you as much lithium. So you have to take like 3 times as much to get, or 4 times as much to get the same amount of lithium. So if you're taking, 900 milligrams of lithium carbonate, you got to take 4 times that to get the same amount of lithium if you're taking lithium orotate. There's also this thing that orotic acid could be mutagenic, meaning it can cause cancer in high doses. No studies in humans, we don't know, but we don't have the studies to back it up. So you can still buy it on the internet and stuff. And if you have bad luck and can't get lithium carbonate, I guess you could do it, but I can't recommend it really. So hopefully I answered that question on lithium orotate.
Quickly, a clarifying question that I've got in the chat. Someone said that they heard lithium orotate can get into the brain better than carbonate. Is that true? It sounds like maybe not.
There's some rumor that it can get up, and there's some controversial evidence one way or the other. I mean, it is possible that it could. The studies I read, there's a rationale behind it, but when they actually look at it, it's a little bit unclear. It's not that easy to go into someone's brain and find out how much lithium is in there after they take a pill. So it might work better, but remember, you have to take a significantly more amount. Even if it's not 4 times as much, you still have to take more. So you're getting into this realm of like, how much am I taking and so forth. So how much should you take? Well, this is some studies looking at, and as a reminder, lithium's been around for a long time. These are studies from the 70s and 80s. And what they did is they divided up the patients at like what their serum lithium level was, and then how likely was it for them to have a relapse. So you could see that people who got below like 0.4 in the labs had a much higher rate of relapse. But not everyone, it's not 100%, it's only, well, I shouldn't say only 60% is a lot. Whereas if people were in this range of, in their terms of their serum lithium, they had much better, much less likely to relapse. Here's another study that shows they divided the patients up into 4 different categories. And so you can, and one of the points that they make is there does seem to be a linear relationship, so that like the more you take, the less likely you are to relapse. But on the other hand, you still get some benefit even at the lower dosage. So I've definitely taken the tack of like try to put the person on lithium. Sometimes people find it kind of helpful. It's not 100% curative, but it can be really helpful, because if they get to the 100% curative level, like they never have any episodes, they have like intolerable side effects. But I find that sometimes just having a middle doses can be beneficial, which is a little different than other meds where you're either on it or you're off of it. And people say don't take middle, like intermediate dosage. Whereas I think lithium for individuals, it depends on the individual. But if you can't take high doses, you might try taking a lower doses. And my recommendation is take as much as you can until you have side effects. If you have side effects, then back off a little bit. So if you're doing it gradually and you're increasing the dosage gradually, you shouldn't get blown away by side effects. You'll have like mild side effects. And if you find like you have a little tremor or you're starting to pee a little bit more than you really want to, like most people can tolerate a little extra pee, but if it's really getting in the way, then you can cut back a little bit and see if that helps. So. Now, kidney side effects. These are the 2 like most problematic side effects, I would say, because these are long-term side effects that may not be reversible. Those are kidney problems and thyroid problems. Other side effects that are really common but are not as problematic, as it were, would be increased urination, upset stomach, diarrhea, dry mouth, metallic taste in the mouth. You could like decrease the dosage and stuff like that, and so. And change the time of day you take it, and there are little tricks that you can do to make those better. The thing with kidneys is the longer you take the lithium, it does kind of increase the wear. Like all our kidneys are like, we have wear and tear on our kidneys. So think of it as like it doesn't cause kidney damage, but it can accelerate it, or it adds on another layer onto your kidneys. So for example, if you get beyond the age of like 65 or 70, your odds of having renal problems is about 10%. If you're on lithium and you've been on it for like 20 or more years, the odds are more like 20 or 30%. So it like the more you take, the more problematic it can get. So typically most people with healthy kidneys, you can take lithium. Usually, I mean, if you get blood tests once a year, you will detect a problem well before you are symptomatic from it. Like you won't be able to tell if your kidneys are like not working as well, because we have a lot of excess like capacity in our kidney function. It's not as if we're working our kidneys at their 100% maximum need all the time. We have a lot of redundant capability in our kidneys. So I think a typical person can expect to have at least 20-30 years of taking lithium without a problem for their kidneys. But most importantly, either way, is just to get a blood test and check your kidney function once a year. That should be enough to prevent you from getting into real bad trouble with your kidneys. And you can adjust, you can either stop or adjust the lithium dosage at that point. I want to say one thing is a lot of times people prescribe lithium twice a day or 3 times a day. It's really much better to take it once a day. I'll get into that in a minute. The other side effect with lithium that can be permanent is the thyroid insufficiency or thyroid inhibition. Most doctors that I talk to, including endocrinologists, will tell me hypothyroidism is a disease we can treat. And it's much easier to treat hypothyroidism than it is to treat bipolar disorder. So if there's a question, yes, your thyroid, and it sucks. You were born with this thyroid gland, and the thyroid could be inhibited. Not always. I shouldn't say it's even that common, but it can be inhibited by the lithium. By the way, people with bipolar disorder have a higher rate of thyroid problems anyways. So that's something just to be aware of. So if you love your thyroid, then you have to be careful with lithium. If you are like have the same opinion as most doctors, we can give you a pill that will substitute for your thyroid pretty nicely. And it's pretty easy from a doctor's point of view to make sure, you know. So I think of the thyroid as like is an emotional issue, and I don't blame people for not being worried about it. But on the other hand, I would say from a medical point of view, you're not going to die of hypothyroidism. You know, that's not going to be a problem. Any other questions about lithium side effects? Okay. This is just a study, and I don't need to go into great detail. This just goes to show you the amount of lithium. QD means once a day versus BID. So when they had people who, and this was a study looking at long-term usage. So on average, these people, so this is not a huge study. They only had 28 patients in the study who were taking lithium once a day. They were taking on the average of 8 years, and their lithium levels were 0.9. The rate of renal sclerosis or fibrosis, which is like abnormalities on a biopsy, was about 5%. Whereas if people took it twice a day, or TID means 3 times a day, you could see a much greater rate of sclerosis or fibrosis. Now, just because you have sclerosis or fibrosis doesn't mean your kidneys are kaput either, but it would be one of those things that indicate we might need to make an adjustment. Again, you typically would not need a kidney biopsy. That was just for the purposes of the study to check on your kidneys. You just get a blood test. Okay, so basically, in this study, patients on lithium twice a day or 3 times a day were much more likely to develop sclerosis or fibrosis. And the title of the study, lithium treatment, does the kidney prefer 1 daily dose instead of 2? And the answer is yes. The kidneys like it when you just take 1 dose a day as opposed to twice a day. Because what happens is this is the theory, is when the level in your body goes lower, if you just take it once a day, you can imagine your blood levels of lithium goes lower. Your kidneys like that. It gives them a chance to recover. If your kidney, if you take it twice a day, you have a more even level of lithium through your bloodstream all day. The kidney doesn't have this chance to like recover or rest, as it were, so much. This may beg the question of what about lithium every other day? And they did try that, by the way, and I didn't include that study, but in patients who took lithium every other day, unfortunately, they had a high rate of relapse. People started getting more mood episodes, even though they increased the dosage to compensate for the only taking it every other day. It does seem like it's going to be a problem. Yeah. So if you're interested, you can look this up on medscape.com, the article, and if you want to take a screenshot here, just take down the number. It's 964-843, or just Google it, like lithium works for bipolar disorder, why aren't we using it? You can hear these 3 very famous, well-known, reputable psychiatrists, psychologists talking about the use of lithium. I think it's about a 10-minute video, a 24-minute video. Okay, so just to summarize, lithium is the best studied with the highest efficacy compared to other medications, as well as compared with placebo, has this unique anti-suicide effect. We have this long-term experience of more than 70 years now with lithium. It has these side effects that, in my mind, the most important ones for people to know about are the thyroid and the kidney. And because of the kidney, it's best to use once a day, and if possible, use the immediate release. And then epidemiologic or naturalistic studies show superiority over other medications. It also has this anti-suicide effect that I didn't list here. But it really works best as a preventative, a prophylactic agent. So like once you're really manic, taking lithium takes a long time for it to kick in. Once you're really depressed, lithium doesn't seem to help as much. Really, lithium is really best to prevent manic episodes. And for those of you who have manias that are followed by depressions, that could be, you will get rid of those depressions that follow those manias. Someone was asking me a little trivia question not long ago. Lithium batteries, I don't know if you've heard, the cost is going really up. And I read that the cost of lithium carbonate might get up to $80,000 per ton. So how much does that translate into, or will it increase the cost of the lithium carbonate pill? Well, I did a little calculation, and 1 ton has about 900 million milligrams in it. And if that's $80,000, 300 milligrams would cost 2.6 cents, almost 3 cents. So it might add an extra 3 cents to the lithium pills that you're taking. And it turns out that most of the cost of lithium carbonate pill is in the distribution and the manufacturing. It's not in the lithium carbonate itself. The lithium carbonate is very expensive. You can dig it up out of the ground, right? So. Okay, that's it for lithium. That was like a little trivia thing about lithium there. Okay, so divalproic. I'm not going to say that much about it. It's called Depakote, valproic acid, sodium valproate, depakine. I'd say it's almost as good as lithium, but lithium is still the gold standard. I'm not going to say anything else about it. Other mood stabilizers, these are not true mood stabilizers, although they may be helpful with augmenting other agents. They don't prevent manias is the main thing. So if you're on these meds and you get a mania, you will still have that post-manic depression that occurs with so many people with bipolar disorder. They do have some benefit in terms of anxiety or other types of things, but in general, not an anti-manic agent. And so that's where to my mind, the real benefit of, like, if you can prevent a mania for many people with bipolar disorder, they are going to live their lives as normal. So as they want, I guess. So, okay, so that's the mood stabilizers. Any other questions about that?
No, we're good so far.
Okay, last and long. So let's talk about atypical antipsychotics. These are most helpful for acute mania and psychosis. They can terminate early manias, and they're divided up into two classes. This atypical antipsychotics, which is what we basically use now. So when we use the term antipsychotic, we usually mean, and we have these traditional antipsychotics. So those of you who may be older, you may remember we had older medications like Thorazine or Mellaril, Haldol, and they still can be quite useful, by the way. But most people like to use atypical antipsychotics, and I'll tell you why in a minute. So the questions we had about antipsychotics is, how do you talk to them about possible short-term side effects and long-term side effects like tardive dyskinesia? Do you find it common that patients taking multiple medications to begin having a growing list of side effects and need to decide whether side effects are worth the possible improvement? You definitely do. And in general, again, I'm an expert in bipolar, so not so much schizophrenia, but in general, it's better to be on a mood stabilizer if you have a mood disorder and not so much on antipsychotics, and better to use antipsychotics for when you need them. Now, another question was, the family member takes an antipsychotic, but still has auditory hallucinations, what to do next? There's a whole bunch of different antipsychotics, how best to think about it. I'll try to answer this question. I'll go through the side effects themselves, but basically it takes a lot of work and effort to understand these kinds of things, and learning about them and having a discussion is really important. I think the best way is probably learn about them as much as you can on your own, and then go to your psychiatrist with specific questions. Because, psychiatrists, we take years to learn about this. We have these courses for our residents and medical students to learn about antipsychotics, and they're like the smartest people on the planet. And it takes them hours and hours of learning and lectures and study to learn about antipsychotics. So if you have a 15-minute visit with a psychiatrist, guess what? He or she is not, even if they're the best teacher in the world, they're not going to be able to communicate as much knowledge as you might want to have about antipsychotics. And fortunately, we have the internet, so you can read a fair bit about it. We have organizations like NAMI that have resources about antipsychotics. So I highly recommend that. Now, family members taking antipsychotics, again, and it still has auditory hallucinations. I presume it's kind of more like a psychotic disorder, like schizophrenia. I'm not an expert in this area, but I've learned some from my colleague Damian Rose, who's an expert in antipsychotics. One thing that I found very interesting from him is high doses of antipsychotics are not necessarily better than low doses. So he takes a much more hands-off approach in terms of, he doesn't try that hard to get rid of, let's say, auditory hallucinations, unless it gets in the way of the person's life. So if the auditory hallucinations are manageable, the goal in life is not to get rid of auditory hallucinations. The goal in life is to live a good life. And if you can still do a lot of the things that you need to do despite having some of these voices in your head, that would be satisfactory. And sometimes in order to get rid of, like, stamp out auditory hallucinations, you have to get up to such a high dosage of medications that it's not worthwhile. So really, you have to talk with your doctor. If you're taking a medication that doesn't work, but you still have symptoms, I think the next best thing is to talk with your doctor about different options. But I think one thing is not to over rely on antipsychotics, but there are other options on helping people to live with auditory hallucinations, for example, or how to like get them. So once they're kind of in this manageable zone, how to get them even in a better manageable zone. Maybe that'd be even another way to say it. Questions about that?
Nothing so far.
Okay, so I run a group for people with bipolar disorder, so I talk about antipsychotics, and so it's certainly helpful. I'll have an hour to talk about antipsychotics with someone. That's a big difference than having 15 minutes. I think Claudia had her hand up.
Oh, I didn't see that. Claudia, did you want to ask a question? Sorry.
Yes, I was the one that submitted the question about the medications and still having my son still having auditory hallucinations. He went through a series of antipsychotic medications that some of them had horrible side effects on him, and finally settled on clozaril. And he leads a pretty functional life, but sometimes the voices are really, or the voice is really horrible. That does get in the way. But I guess doctors or his psychiatrist doesn't want to mess with any more meds because she feels like he's had already a bunch of different kinds, and many of them have these side effects. And so I was just wondering if it would be possible maybe to lower the clozaril and introduce another one. I don't know if they have come up with new medications.
They've come up with new ones, but I don't know if they're any better than clozaril is supposed to be the best. I mean, the problem with clozaril is it can cause these blood problems. You got to get blood tests relatively frequently. So,
right.
But even so, it is the best one, but it also has side effects. So I think one of the thing is to think about, like, is it worth it to try something else? That's it's a little bit of a, after a certain point, you're definitely getting like, there's more antipsychotics you could try, but since they haven't been shown to be better, is it worth it to try? I guess that would be the question. Many people with schizophrenia and psychotic symptoms have been on multiple different antipsychotics. And I think after you're trying like maybe 4 or 5 and you're on clozaril, it may not be that much more helpful to go beyond that. There is some studies looking at people who are on clozaril who can get ECT. My experience with that, with patients with schizophrenia who are already on clozaril but still have ECT, can be somewhat helpful, but it doesn't kind of get rid of the schizophrenia. It might help them with some of the last residual symptoms, but it's quite an endeavor to get ECT for that reason. But it is a possibility. So
it's another medication.
ECT is electroconvulsive therapy, formerly known as electroshock therapy. I don't know if we'll have time to talk too much about it today, but I'll have some resources at the end that you can look at if you want.
Okay, thank you. And if you could talk about the side effects, I would really appreciate it.
Okay, so one of the things
sorry.
Yeah,
I got a quick
ahead.
question about Zyprexa. Someone asked, is Zyprexa an antipsychotic, and is it good for sleep aid?
Zyprexa is an atypical antipsychotic, also called olanzapine, and it is very sedating, so it can be helpful in sleep. So it's called olanzapine. Now, these are the pharmacology of atypical antipsychotics. So one of the things I want to say about atypical antipsychotics is that even though they all are in the same group as atypical, called atypical antipsychotics, they each have different effects on different neurotransmitters. So let's just take olanzapine for a moment here as an example. That's Zyprexa. This pie chart represents how much effect it has on different neurotransmitter receptors in the brain. Okay, so M1 is a kind of neurotransmitter called muscarinic, H is histamine, 5-HT is serotonin, and their serotonin receptors have multiple different kinds, subtypes, and one of them is called 2A. So this represents how much effect this has on serotonin 2A. Dopamine is D2, alpha blockers, and also serotonin 2C, which is another subtype of serotonin receptor. So the main point of this is not that you have to memorize all these things, but just to see that, look, each one of these beach balls, as it were, looks different, right? Each one of these beach balls looks really different. So each antipsychotic has a different effect on different neurotransmitters. And so therefore they are kind of more different than each other than say serotonin reuptake inhibitors or benzodiazepines. these are they're really kind of different. So if you try one, doesn't mean you shouldn't try another one. On the other hand, there's a gazillion of these things out there, and I don't know if I would try after like 5 or 6, that might be plenty, So here are the atypical antipsychotics. If you went through life and wanted to try every single one, I suppose you could, but it's a long haul. And the odds of you getting better after trying 5 or 6 of them to try yet another one, I think is relatively low. So, and there isn't, the research out there about combinations of different antipsychotics has not been positive. It doesn't really show a particular benefit if you're on more than one antipsychotic. So what's the bottom line for bipolar disorder? Antipsychotics are better than mood stabilizers for acute mania, acute psychotic symptoms. But if you're having an episode of mania, oftentimes a combination of antipsychotics and mood stabilizers might be best. Well, why don't we just have everyone on antipsychotics if it works for acute mania? Well, the 2 main problems: one, sedation, and with that, even though maybe I should list it as a separate problem. 1 is sedation, 2 is metabolic syndrome, which includes weight gain and diabetes. And the reason why I group them together is if you have more sedation, if the antipsychotic has more sedation, it typically has more risk of a metabolic syndrome also. I don't know why that relationship holds, but it does hold. And then it has a risk of EPS, which are EPS is short for extrapyramidal symptoms, but really they're just neurological symptoms. I'll just call them that. And there are different kinds of things that are acute dystonic reactions, like people might feel like spasms of their neck muscles. That's called a acute dystonic reaction. Akathisia, which is a kind of restlessness. People in severe forms can say they feel like jumping out of their skin. Parkinsonism or pseudo-Parkinsonism. It is actually a kind of Parkinsonism, but it isn't the same cause as Parkinson's disease, which is it's not because of antipsychotics, but you get the same symptoms in that the person gets rigid and slowed down when if they take antipsychotics. Now, these extrapyramidal symptoms are much less common with the atypical antipsychotics. So that's why we like to prescribe them. Tardive dyskinesia is involuntary muscle movements, usually of the mouth and hands, that may not be reversible. So that's why people are very afraid of tardive dyskinesia. It doesn't occur like right away. You take 1 dose and forever you'll have a mouth problem or something like that. But after taking it for a long term, usually there have been some case reports of people getting tardive dyskinesia after even 6 months of usage. I think that's pretty unusual. That's pretty rare. The only thing I would also say is people with schizophrenia have a higher risk of tardive dyskinesia anyway. So even before we had antipsychotics, psychiatrists noted, oh, this person has all these like abnormal muscle movements of the mouth and hands, and may be part of schizophrenia as well as antipsychotics. So if you want to read more about extrapyramidal symptoms, there's a wiki on Wikipedia. So those are the side effects. Any questions there about the different? Claudia, I see you still have your hand up. Did you want to ask another question?
No, I'm sorry. I forgot.
No worries. I'll lower your
it.
hand for you. It's okay. I can lower it for you.
Someone asked a question before our presentation, and I think it might be a good place to include it. They asked, they're taking a high dosage of clozapine and they're still getting insomnia. Is there a reason why? And if clozapine doesn't help relieve psychotic symptoms, what other treatments are effective? Is ECT effective for schizophrenia?
Okay, so usually antipsychotics work better than ECT in that you can take them ongoing. ECT, they work acutely, but a lot of times symptoms begin to come back once you've stopped. Now, for people with mood disorders, sometimes you break the cycle with the ECT, and then they're on a different kind of regimen of medications and they don't fall back into a depression. Whereas for schizophrenia, I think it tends to be more in terms of like having some like thinking problems. And ECT doesn't help with the thinking problems per se, but it helps with the acute like psychotic symptoms like hearing voices and stuff. So I'm not sure if I answered the question. Does someone want to ask it again, or is there some thing that I missed? And it's a, who wants to get electroshock therapy? It's just not that common that people want to do it. And unless the antipsychotic doesn't work, usually people don't want to get ECT.
Yeah, and then I guess wondering, is clozapine also used for insomnia? It sounds like this person's also trying to use it for insomnia.
It can be pretty sedating, so that you would use it for insomnia. It would be reasonable to try to use it for insomnia. So someone in the chat mentioned to take metformin. for this metabolic syndrome, and that's becoming more and more common. There are actually newer anti-diabetes medications that may prove to be really helpful for people on atypical antipsychotics. These are like the glucagon like peptide type of things. They're super expensive right now, which is unfortunate, but hopefully the price will come down, and I see those as being really helpful. So ECT, I'm sorry, what was the question again? So clozaril is supposed to be the best antipsychotic out there. So if you're on it and you haven't had a problem with it, you probably don't want to. If you're still having problems with sleep, I would recommend making sure you're doing all the other non-pharmacological things right first. There's an app on your cell phone that you can get, or you can engage in a treatment called CBTI, that's cognitive behavioral therapy for insomnia. And there's a good free app on a cell phone, or I think you might be able to use it online, called CBTI, and it's put out by the Veterans Administration, and they make it free. And someone has a question about clozaril effects on liver and kidneys. As far as I know, it doesn't. Most antipsychotics are metabolized by the liver, so if you have liver problems, then it could affect how much antipsychotic you need to take. But in general, I don't think of it as having negative effects on your liver. By the way, going back to Depakote, occasionally people have allergic reactions to Depakote, and that's called a hepatitis. So they may have a hepatitis with Depakote. It turns out that that's much more common in children. And so when they do these studies on epilepsy and in kids and stuff, they get Depakote and anticonvulsant, they give it to kids, and so they get a lot of hepatitis with the kids. But when people are adults, for whatever reason, it's not that common. We still check for it, but it's not that common. So that's a Depakote side effect. Antipsychotics can also be injected once a month. That can be really helpful for those of you who struggle with taking pills regularly, whether it's from a psychological point of view or just forgetting. Injectables can be very helpful for people, and some people really like it. Okay, so just to summarize, antipsychotic and bipolar disorder, it's a very helpful class of medications. It's divided into two subclasses called typical and atypical, or traditional. And it's most helpful for acute mania and psychosis. Most significant side effects are sedation, metabolic syndrome, and EPS, which is that neurological symptoms that I mentioned. I think it's still best used as a PRN for people with bipolar disorder, PRN meaning as needed, and as part of an early action plan. So if for those of you who don't have an early action plan, you should have one, whether you have bipolar disorder or any severe psychiatric disorder where you might need to be hospitalized. Early action plans are asking you to think ahead about them and make a plan. That's an early action plan. You can, Google it and find them online. Kelly has her hand raised, or his hand raised. Kelly, do you want to ask your question? You're on mute, I think so.
Hi, I'm so sorry. My button was disagreeing with me. My son, I wrote in a little earlier, my son is 11 years old and has pediatric bipolar, which I know is a little controversial and maybe different than the typical adult bipolar that you probably mostly talking about. And then in listening, it sounds like the true mood stabilizers tend to be gold standard, but I'm wondering if that tends to be more for adults, because we're working with a psychiatrist who is starting with the atypical antipsychotics instead. And I was just curious if the pediatric angle changes things.
I think it depends on what the clinical picture looks like. So if the clinical picture looks like this is just a little kid who has clear-cut manias like euphorias and stuff like that, where they're talking really fast, if it's a classic kind of description, then lithium is usually the thing that could be tried first. If it's not so sure and there's more like temper tantrums, irritability, and then maybe the atypicals might be the way to go first. Without knowing it, I can't say.
Right.
Certainly, I mean, I certainly have met kids who, bipolar disorder typically manifests in adults. So child and adolescent psychiatrists might have a little less experience with lithium. Even many adult psychiatrists on our training programs nowadays don't get enough practice with how to use lithium. But so
no, that's
it's
helpful,
worth a try.
especially with mania.
I've definitely heard some patients in kids who got on some lithium and it made a big difference. So
Okay.
And again, when you say makes a big difference, you have to take it for several weeks. It's not like you take it and the next day the person will be better. But you'll see
I see.
gradually over time. Sometimes you need months to find out, okay, well, the person does this, the episodes seem less severe and stuff like that. So
Okay. It sounds kind of like mania is one of the big directors
yeah,
in
I think
making
so.
that decision. That's really helpful to think about.
Yeah.
We've had, I think, some mixed episodes, but no clear-cut mania. So it makes
Yeah.
sense. Thank you.
But if a few don't work, then you might think about lithium. I think and people are worried about the side effects and stuff, but I mean, I think of lithium as being better tolerated than atypical antipsychotics, you know. So,
Okay. No, that's wonderful. Thank you. I appreciate that. It gives
Okay.
me something to think about.
yeah. So that's it for the meds I'm going to talk about now. So I know we have 10 minutes left. So we talked about mood stabilizers, atypical antipsychotics. Antidepressants are out there. I'll just touch on like withdrawal symptoms in a minute, and sedative hypnotics. Those are like benzodiazepines typically. So we have a couple of PTSD questions. I'm not a PTSD expert, so the answer is, the correct answer for me for both these questions, I don't know. So will it be possible for someone living with bipolar 1 to take psilocybin for PTSD? I don't know. I think my thought is that if you're prone to psychosis, meaning if you're prone to like hearing voices or getting paranoid or becoming delusional, taking psilocybin is more dangerous. You have to be very careful because psilocybin can trigger psychotic episodes in people who are vulnerable to that. So that would be my major. And right now, we really don't know. I mean, psilocybin is for PTSD. It's not for bipolar disorder. So that's how I would think about it. And then what is the latest best medication treatment to treat chronic insomnia due to anxiety? And I think C, PTSD means complex PTSD. I don't know the answer to that. I think we don't have any studies looking at that. I think people try to treat that with atypical antipsychotics, and hopefully it works and you don't get a lot of side effects. That would be I mean, I presume that people have already tried like benzodiazepines and Ambien and stuff like that. So typically we don't think of, pharmacology as necessarily the best thing for PTSD. Other things like I think prazosin is frequently used. Like again, I don't treat people with PTSD that much, so prazosin is more like a medication, or clonidine, something for sleep for people with PTSD. So, and those are not latest or newest; those are old. So, okay. So more questions. How to triage down? And I think the person meant I wrote triage, but I think they meant to write, or I meant to write taper down or titrate down is the two verbs that titrate or taper down meds without causing symptoms to return. And so one of the things that was shown like in early studies of lithium is like if you took people off lithium and tried something else, the rate of relapse is really high. But partly that was due to if you take someone off anything cold turkey, you're more likely to get a risk of relapse. So when I say quick stopping, if people stop the lithium or other meds in less than a month, you're more likely to get withdrawal symptoms or have a relapse. But there's something about, there's not just symptoms returning, there's also withdrawal phenomena. So that's a little different than a relapse. There's also direct withdrawal effects from medications. Here's a couple articles about antidepressants. This is from the New York Times a couple of years ago. Many people taking antidepressants discover they cannot quit. And this is a New Yorker article about the same issue, the challenge of going off psychiatric medications. So what are the symptoms of antidepressant withdrawal? I'm not gonna, this is like a little little exercise, but all of these can be symptoms of antidepressant withdrawal. And you can see that some antidepressants are more likely to cause withdrawal than others. So in this study, Prozac was less likely to cause withdrawal than other antidepressants. And because medications that have a shorter half-life, like Zoloft or Paxil, are more likely to cause withdrawal. Similarly, if you take benzodiazepines and they have short half-lives, things like Xanax, if you get used to taking Xanax and you stop that cold turkey, you'll have a lot stronger withdrawal than if you're taking Klonopin or clonazepam, which has a longer half-life. I didn't include anything about the pharmacology of half-lives and how that works out. I probably should have, because I love that little piece about half-lives, because it's a very important concept that I think every patient should know, but maybe at some future time. So these are symptoms that can occur. Now, some people have found that they get symptoms, typically symptoms of withdrawal occur within 3 days of stopping, or sometimes, just decreasing the dosage of the antidepressant. Most of the time, if you're doing it slowly, symptoms are often mild and resolve spontaneously within a few weeks. But in rare cases, they may persist for a month, leading to what they're calling a persistent post-withdrawal disorder. Okay, there are a couple of websites that I wanted to alert people to about how to decrease antidepressants. So I don't have time to go through it all yourself, but you can look at these websites and find like little schedules about and concepts and like discussions and fora about how to decrease antidepressants. And then there's another one for benzodiazepine withdrawal. This is Benzo Buddies. And then finally, there's the Withdrawal Project. Are you thinking of coming off psychiatric medications? I was told, but I haven't found this myself, but I haven't done a clear search of the Withdrawal Project website. It tends to be a little bit more anti-medications than the other ones. The other ones are more like, okay, this is just what you do. If you want to go off, try to taper off slowly. This one has really detailed descriptions of how to go off. And I've been told that they're a little bit more negative about psychiatric medications in general. I don't know. I just wanted to give you that caveat just so you know what you're getting into. Okay, so that's it about antidepressant withdrawal phenomena. And by the way, all these things also, benzodiazepines, antidepressants, atypical antipsychotics, you don't get withdrawal phenomenon from mood stabilizers so much. They have very long half-lives, so it's rare for people to develop withdrawal. But in case you want to go off of them, it's much better to go off slowly. Also, if turns out you really needed them, if you go down slowly, you may not remember that stuff I went to before about having intermediate doses of lithium could be helpful. Coming off medication slowly, if you can, unless you're having like a terrible emergency side effect, it's much better to go off slowly of these medications if you can.
Quick question. Someone is a little worried. They take a combination of Wellbutrin and Prozac, and a quick Google search says that makes them more prone to seizures. Do you have any opinion on that long term, if that's pretty high risk or?
It's pretty low risk. I mean, many things will affect whether you're likely to have seizures or not. So like staying up all night will increase your seizure risk, I think, much greater than taking Wellbutrin. So, and the older you are, the less likely you are to have seizures also. So those are a couple of things. So it's very rare for the cases where they had patients who developed more likely to develop seizures was in people who had eating disorders. And the thought there is when you don't eat enough, your electrolytes get out of balance and you're again more likely to get seizures. So whether someone gets seizures or not is kind of like a lot of different factors add up together that increase or decrease your risk. It's not like one thing causes a seizure, although one thing could push you over the edge, but those things are like Wellbutrin is a relatively weak I mean, I can't say it doesn't because it will increase your risk of seizures, but like I said, it's pretty modest. If you're living a normal life, you're very unlikely. And if you take the dosage as recommended, very unlikely you'll have seizures. And it doesn't get worse as you get older. In fact, as you get older, it gets harder to get a seizure. And I don't know if you know this, but like little babies, they have these things called febrile seizures. Like if they just have high fevers, they can get a seizure also. And seizures in and of themselves, since I do ECT and we trigger seizures in people, are pretty benign and maybe even helpful for people, except in the fact, if you're driving and you have a seizure, you could crash, stuff like that. Okay, so getting on to seizures now, interventional psychiatry. So what is TMS and how does it work? Is it better than medication? TMS is transcranial magnetic stimulation. I thought I don't have any slides on this. You can look this up on Google, on Wikipedia, transcranial magnetic stimulation. How does it work? We don't know how any of these meds work because we don't know what causes bipolar disorder or schizophrenia. If we knew exactly what caused them, then we could say, okay, this is how it works. We have theories about how some of these things might work, but we don't really know exactly. So the theory behind TMS, again, we don't know what causes depression. We don't know. We do know that certain parts of the brain seem to be overactive in depression. Certain parts of the brain may even atrophy in depression. So TMS, strong magnetic fields applied to the head every day, and what it does is it will actually, what the idea is, we think that it generates electrical currents in the brain, but you don't have a seizure, but it will stimulate certain parts of the brain, hence the name stimulation. And that's how it makes depression better. They're coming out with new, more powerful forms of transcranial magnetic stimulation that are very exciting and may work better. I think of transcranial magnetic stimulation as doesn't work better than medications, but it works as well as antidepressants. But normally if you try one medication, an antidepressant, it makes sense to try a medication in a different category. So like you don't do, you might try one. If you try Prozac, you might try Zoloft. So they're both SSRIs. So those are, you might try two. But after a couple in the same category, you might look at a different antidepressant. So when I had my slide up about different antidepressants, you can see the different categories. I would think of, in terms of efficacy, effectiveness, TMS is effective as antidepressants, but think of it as another category. Except now they have these new forms. I think it's called like theta burst stimulation that may be even more effective. But I don't, again, I'm not a TMS practitioner. I don't know that much about it. ECT, how to get over the anxiety of ECT, I don't know. Do not watch One Flew Over the Cuckoo's Nest, even though that was one of my favorite movies. Or if you are worried about ECT, you could watch One Flew Over the Cuckoo's Nest. If you watch it carefully, he is fine after they get the TMS. He's goofing around with his buddies to pretend that he's like a zombie, but he's actually totally fine after the ECT. It's when he gets a frontal lobotomy, that's kind of the ending of the movie. That does change him. But the ECT, he's totally laughing and just kind of joking around with people. But I don't have time to go into the history of ECT. There are a lot of laws and stuff around it. Here is a QR code for our UCSF ECT frequently asked questions. So if you have a smartphone, you want to take a picture of it, or you kind of want to scan this QR code, you can do so now. I'll leave it up for just a couple minutes while I take any more questions, but I think we're out of time. It's 7 o'clock. The best talks are the ones that end on time, I feel. So there you have it. And thank you for participating in this. I love to teach. I love it when people are curious and want to learn.
Thank you so much for all of this information, Descartes. And after the presentation, I'll send out some of the links that you've shared during your presentation. So if folks aren't able to screenshot the QR code, I'll make sure that that's sent out in an email, and along with some other things. Some quick asks from everybody. We've got 2 surveys that really help us as an organization. If you could please fill out the demographic information. It'll just take a minute. And then the feedback survey is also helpful. So we know what kind of programming y'all are interested in. And finally, if you're interested in donating, we would love to have more free programs, as many as possible, as large a variety as possible. And donations help with that. Of course, though, I love to just say, if you are not in a financial place for that, please don't even consider that. We totally understand. And we're really glad you all showed up. Thanks so much. And thank you, Descartes.